prospect of curing patients with hepatitis C with interferon-free regimens is imminent and inevitable, and represents an extraordinary development in the history of medicine at this time. We've been using interferon-based therapy since the early 1990s, and for all the years that our patients endured all the side effects of interferon with clearly suboptimal rates of cure, we wondered if we might one day be able to dispense with it in our treatment regimens. We wondered all the more about this when HIV therapy became refined, and it became quite clear that you could suppress viremia in people with HIV infection almost all of the time if you put together sufficient combinations of antiviral drugs so as to confer profound viral suppression, but also present to the virus a very high barrier to resistance, so that on a molecular level it would not be able to mutate and wriggle free from the suppressive effects of the medications. The major limitation in HIV therapy has been that the virus is archived. Its genome, its genetic material, is embedded deep inside cells, even inside human chromosomes, so that we've never been able to think about eradicating HIV completely, but we've become very good at suppressing it. The same thing was happening during the ensuing years with hepatitis B, also not a curable disease, but at least nowadays an eminently suppressible one. We have felt for years now, based on long-term observations of patients with hepatitis C who have had what we call a sustained virologic response, which means undetectable virus 6 months after the end of course of therapy, that it would rarely come back after that. And we've also learned enough about the biology of hepatitis C to know that it doesn't embed or archive its genomic material the way the other two viruses that I mentioned are capable of doing. Therefore, it's always seemed theoretically possible to us that if we came up with a good combination of well-tolerated oral antiviral agents, analogous to the other viral infections, that we might not only be able to suppress HCV replication completely, but that somehow in due course it would wither or decay away. Whether you need an innate immunologic bang to do that, or whether the virus goes away with a mere whimper, we don't know. But the proof of concept that you could profoundly suppress HCV with an oral antiviral agent was demonstrated over a decade ago. But it's taken the ensuing years to develop sufficient numbers of safe antiviral drugs representing different classes to now be entirely convinced that the goal of interferon-free therapy curing patients in a very large percentage of the time is inevitable. And there's just now one study after another, speaking in late 2013, that has given us a very clear idea of what an optimal antiviral regimen, if you will, capable of curing seemingly over 90% of patients needs to consist of. We've learned about different classes of drugs, like nucleotide polymerase inhibitors, which mimic the building blocks of genetic material and can trick viruses into incorporating those building blocks, which then end the prolongation of a chain of RNA, which viruses need to replicate. We've learned about non-nucleoside polymerase inhibitors, which inhibit the same enzyme that directs the synthesis of the virus's genetic material, but by changing its shape rather than affecting the active site. Of course, protease inhibitors, which I should have mentioned first because they were the first to come along, exist in abundance now. In 2011, there was a major advance in medicine when telaprevir and boceprevir were approved, but they were approved with interferon and ribavirin. Surely a major advance because of the increase in cure rates conferred, but still carrying a burden of additional side effects over and beyond what patients already experienced plenty of with interferon and ribavirin. And 2011 was actually a pivotal year because it was the year in which the first patients who were cured of their HCV infection with oral antiviral drugs alone, albeit in small numbers since these were early studies, were demonstrated. In a mere astonishing year to year and a half later, there had been a number of phase 2 studies reported in which many dozens of patients, or even hundreds of patients, had been cured a very high proportion of the time with robust combinations of antiviral agents like protease and NS5A inhibitors, or protease inhibitors combined with NS5A inhibitors and non-nucleotide drugs, as well as ribavirin, a highly curative regimen which actually firmly demonstrated that prior non-responders to interferon could do nearly as well, actually just as well, with over 90% cure rates in genotype 1 as patients who'd never been treated before. This was important because the first signals in 2011 and early 2012 were that prior non-responders to interferon might paradoxically not respond as well to non-interferon-based regimens, and we all wondered what host factors or immunologic factors might underlie that observation. But regimens like the one that I just mentioned to you can overcome whatever adverse host factors are represented by a prior non-response to interferon therapy. Nucleotide-based therapy has become very, very exciting. The nucleotide class represents a class that, at least so far, uniquely combines a high level of potency with a very high barrier to resistance. The virus cannot molecularly alter or mutate the active site of its polymerase without becoming essentially non-viable or so unfit that it can't replicate. So it's very hard for the virus to escape the suppressive effects of a good nucleotide inhibitor. And there is a drug called sofosbuvir, which is a nucleotide that has already completed phase 3 trials and abundantly demonstrated the answer to your question. By curing over 90% of patients with genotype 2 with a combination simply of sofosbuvir and ribavirin without interferon, a very substantial proportion of patients with genotype 3, though not quite to the same degree, and additional work is being done to explore longer durations of therapy or the addition of other antiviral agents. And there are very exciting phase 3 trials being conducted with such combinations as NS5A inhibitors combined with sofosbuvir in particular, and perhaps other nucleotides to be developed later, as well as the regimen in phase 2 that I mentioned that had those very high rates of cure with a protease inhibitor, an NS5A inhibitor, a non-nucleotide or nucleoside, and ribavirin. There are certain other phase 3 programs going on as well, but still a lot of activity in phase 2 demonstrating other regimens representing similar combinations of the classes that I've mentioned. Amongst the questions that prevail are not whether we can cure hepatitis C without interferon, and not whether we can do it most of the time, but whether in fact every patient with hepatitis C will ultimately be curable with without interferon. We wonder about whether we need ribavirin, and studies are underway to demonstrate that, whether that's the case. And we wonder how ambitious we can be about shortening the duration of therapy. There actually is a phase 3 trial going on which contains sofosbuvir as one of the components of the regimen, evaluating shorter durations of therapy to as little as 8 weeks. Many clinicians will be perfectly delighted if a well-tolerated oral antiviral combination can do the job in most patients in 12 weeks. But of course, everything else being equal, the shorter the duration, the better, and certainly it represents a step forward in cost effectiveness as well. So we'll see about all that, but it's an extremely exciting time. Because of the inevitability of the development of interferon-free regimens with high cure rates, many clinicians are deferring therapy at the present time, trying to help spare the patients the need to take interferon, although there are exceptions, patients who clearly do need to be treated now, because we think that in less than 2 years from the time we're speaking together, that there will hopefully be regimens approved by regulatory agencies that entail these very high cure rates of 90% or more for the broad spectrum of patients with genotype 1. We've got work to do in patients with HIV co-infection, liver transplant patients, patients with advanced cirrhosis, and indeed cirrhosis patients need to be studied more extensively to see if modifications of the regimen are needed. But a time of radical change is well at hand.